And let me thank the KGMOA office bearers who gave me the opportunity to present a topic in KGMOA series. Today, my topic of presentation is common ENT diseases seen in clinical practice. Let me share the screen. Is the presentation visible?
Yes, yes.
In this presentation, I'll be dealing with most common conditions in ENT practice. I'll be basically skipping the pathophysiological part, the organisms causing what will be the pathological appearance and all. We'll be mainly concentrating on what will be the patient presenting complaint and how will we see the patient on examination and what will be the medical management which we can do in a peripheral setup. This is the overview topic for presentation is easy presentation. I've divided the topic as 3 headings. So I'll be dealing with first common ear diseases. Perichondritis is one of the major common conditions which we see in OPD. It is actually an infection or inflammation of the perichondrium of the external ear. And most common causes will be trauma, frostbite, burns, chemical injury, and infection of hematoma due to improper aspiration technique. And most commonly, one of the most common cases we will be seeing with high piercing of earrings. The patient will be presenting with severe earache, and on examination, there will be red, swollen, and local rise of temperature over the cartilaginous portion of the pinna. And typically, lobule of the ear will be spared. And there's a Prasad staging for classification, like perichondritis without fluctuant abscess. Stage 2 will be with fluctuant abscess, and stage 3 will be with abscess and perichondrial necrosis, cartilage necrosis. The complications of perichondritis will be subperichondrial abscess, avascular necrosis, which may lead to marked deformity of the pinna. It can also cause infection of the cartilage and fatal septicemia and other rare complications. The treatment will be basically for mild cases. You can apply topical antibiotic creams like mupirocin or soframycin and give oral antibiotics like penicillin or fluoroquinolones. If the pus is pointing and there's an abscess is present, go for an incision and drainage. For that, refer to an ENT surgeon. If an offending factor is actually a earring, second stud, most commonly this type of presentations will be seen with the second stud impacted. Try to hold, if it is a smaller, if the head of the earring is visible, you can catch hold of the tip of the front portion of the ear stud with an artery forceps and lock it and try to remove the shangri portion from the behind, and then apply remove the pus and apply a tight bandage and give a mustard bandage and give a strong course of antibiotic. If fluctuant abscess is present, incision and drainage will be required, and broad spectrum antibiotics like ceftazidime, gentamicin, or piperacillin may be needed. For that, patients need to be referred to a higher center. For prevention of this perichondritis, we have to advise the patient regarding high piercing of cartilaginous portion of the pinna. If at all cartilage is pierced, ask the person to take care of that ear stud with saline compression. If at all any stages of infection is seen, like redness or edema, come to an ENT or take an antibiotic or consult a doctor. And in case of trauma and proper removal of debris and suturing, which should be done under strict aseptic precautions. In case of hematoma drainage, it should be drained under supervision and under aseptic precautions. In case of burns, eschar and debris should be removed carefully to prevent avascular necrosis of pinna. This avascular necrosis of pinna can cause marked deformity of the pinna. Before going to the other clinical conditions, let me familiarize with an otoscope. Actually, all of us are having an otoscope in our family and health centers. Most of us are having an ENT kit in that an otoscope is being provided and it is sitting idle. So it can be used to diagnose ear conditions, and also for nose examination in pediatric age group, we can use an otoscope. For ear examination, First of all, rule out any tragal tenderness. If there is any tragal tenderness or any diffuse edema or swelling in the external auditory canal, you cannot use a otoscope. If these conditions are ruled out, you can use an otoscope. For examining the right ear, use a right hand. Hold the otoscope in a head holding position. Retract the pinna upward and backward, and use a correct size speculum. Then with the little finger can be placed over the cheek, so that there will be it will be acting as a fulcrum and prevent excessive pressure over to the tragus and inside the external auditory canal. Pain will be reduced after introducing the speculum. On examination through an otoscope, we'll be seeing the normal external auditory canal like this, and there is a tympanic membrane is visualized with a normal cone of light, handle of malleus, umbo, and a lateral process. You can see the round window niche and a eustachian tube orifice. This is a normal appearance. So next condition will be pharyngulosis, that is diseases of the external ear. That is, pharyngulosis is actually a localized form of otitis externa. This is caused by staphylococcus infection of the single hair follicle, which will be, since the hair follicles are in the lateral part of the cartilaginous part, this pharyngulosis is confined to that lateral part. It may present as a well-circumscribed lesion, which may progress to a pustule, and then abscess with edema and cellulitis. The patient will be presenting with extreme pain in the ear, and even the movement of pinna will be painful. And opening the mouth and jaw movements will be paining, and our patient also may have ear block and a serosanguinous discharge. On examination, we can see that there will be pinna, touching the pinna will be painful, and there may be tragal tenderness. For eliciting the tragal tenderness, just press over the tragal part of the pinna up inwards. And in the external auditory canal, we can see a pharyngeal well-described lesion. And if it is progressed, there may be pus may be pointing and may be associated edema and inflammation of the lateral canal. If the pharyngeal is small, we can visualize the tympanic membrane and medial canal, which will be usually spared. If the pharyngeal is situated in the posterior part of the external auditory canal, it can cause edema can cause the obliteration of the postauricular groove, and there will be postauricular lymph node enlargement. These may mimic mastoiditis. So the treatment of pharyngeal of the ear will be give an oral antibiotic like fluoroquinolones, cloxacillin, or penicillins. And if the pus is pointing, go for an INT. Topical treatment can be done with earwigs. For making an earwig, take a gauze piece like ഒരു വിളക്കിന്റെ തിരി പോലെ like earwig, impregnate it with antibiotic or steroid cream. So many brands are available like Bestopic and Cordridom. Then soak it completely with that ointment and make it stiff. And use a Tilly forceps or a dressing forceps and slide slowly introduce into the external auditory canal between the pharyngeal and the external canal, and keep it for 24 hours. Ask the patient to come the next day, and if the edema is reduced, pain is reduced, it can stop, or otherwise continue until the pain is subsided. For reducing the edema, you can also use 10% Ictagone glycerin soaked earwigs. This earwigs will be helping to reduce the edema and also have a splinting action. In case of recurrent pharyngitis, one of the sources may be a colonization of external layers with Staphylococcus aureus. So a topical mupirocin may be applied in the nasal cavity. In these cases, always rule out diabetes mellitus and hypogammaglobulinemia. Next condition is generalized otitis externa, and certain factors predispose to it, like narrow external auditory canal, eczema, seborrheic dermatitis. In that cases, plaques may be seen inside the external auditory canal, postauricular region, allergy, humidity, trauma to the ear, especially after swimming and water entry. There will be skin maceration, repeated ear probing with earbuds, or using sharp instruments like tip of the pencil, key, etc. And active chronic otitis media, in that ear discharge will be constantly present in the external auditory canal and cause irritation. The patient will be presenting with pain in the ear, blocked ear, and there will be itching and discharge. On examination, there will be tragal tenderness, and we can see the edema or debris or discharge in the external auditory canal. How to treat it? Give a proper oral toilet. For that, you can use dry mops, or if suction apparatus is available, you can go for gentle suction clearance. And as early mentioned, you can go for ethymol glycerin or antibiotic pulse steroid ear drops, ear wicks, and Ciplox or ofloxacin drops can be used, or can steroid like and aminoglycoside combination ear drops like gentamicin D can be used. Special precaution is to be taken that neomycin containing ear drops should be avoided in cases of external otitis, because this itself can cause hypersensitivity and external otitis. How to prevent external otitis? Avoid water entry. This is otherwise known as swimmer's ear. So for placing, you can use a cotton wool and soak it with petroleum jelly and make it in the round ball, keep it in the external auditory canal. Or swimmers or those who go for diving and all, you can go use custom-made ear molds. Or drying the ear canal by using alcohol containing preparations also prevent moisture. And yeah, it can also use this or alcohol containing ear drops to wipe the whiteness. Another condition is otomycosis, which is actually a fungal infection caused by aspergillosis and can also be associated with candida. The risk factors associated will be humid climate and prolonged use of topical antibiotics for ear conditions, diabetes mellitus, and immunosuppressive conditions. The patient will be presenting with intense itching, and there will be earache and serous discharge, and will be having a musky odor, and they may be having a ear block. On examination, we can see black, gray, green, or yellow. Depending upon the species of fungi, there will be the color of the discharge may vary, and with debris, which will be presenting as a wet newspaper appearance. Or sometimes in cases, fungal hyphae may be seen. How to treat it? As a proper oral toilet to remove all the debris, fungal hyphae to be made. Then use topical antifungal drops like clotrimazole, drops 2 drops TID, or you can use clotrimazole key. In case of resistant cases, always rule out fungal infection in other areas, especially fungal infection in the food, which can cause teeth reaction in the ear. This is a malignant otitis externa. This another condition is always a life-threatening condition which involves the periosteum and bone of the skull base, usually caused by pseudomonas, and most commonly seen in elderly, diabetic, and immunocompromised patients. In these circumstances, when the patient is not responding with local therapy for 8 to 10 days, and on examination there is granulation tissue at the junction of bony cartilaginous junction, and there's a pain and otorrhea, then you have to suspect malignant otitis externa or necrotizing otitis externa, and is more commonly seen in this as previous earlier mentioned diabetes and immunocompromised stage. And if you go for a culture and sensitivity, pseudomonas may be seen, and posterior bone scan like gallium and technetium 67 may be positive, and associated cranial nerve palsy if ESR is more than 100. C-reactive protein is raised, always suspect malignant otitis externa and refer to a higher center. Wax. Wax is one of the most common clinical conditions seen in ENT practice or general practice. It is actually desquamated skin and cerumen. It is normally needed in the ear. When it is becoming more, and it is if there is any obstruction in the drainage, it may become thicker and impacted. And the patient may present with ear block, itching, and when the water gets soaked inside the ear wax, the patient will be having a blocked ear, hearing loss, and itching. So for that treating impacted wax, we can soften the wax. We can use the soda bicarb ear drops, which we'll be having in KMCL supply, or other commercial drops like Vaxim or Vaxido. Any of these preparations can be used. For that, ear drops, 4 drops of this ear drops should be used, and it can be applied to 3 times a day or 4 times a day. For applying the ear drops, Ask the patient to lie down and with the affected ear up, then gently pull the earlobe upward and outward to straighten the external auditory canal. Then apply 4 to 5 drops of ear drops. Then gently push the pinna inside and outside to facilitate entry into the ear canal. Then at least stay there for 2 minutes and repeat in the next other ear if symptoms are present in both ears. Once the wax is softened, you can go for syringing. Syringing can be done in any general practice. No ENT surgeon is needed. So you can use a 20 cc syringe and a scalpel. I usually use a scalpel, 23 gauge or 24 gauge scalpel. The tip is cut and can be reshaped according to the size of the external auditory canal, or you can use a cannula. Always use water which is at a body temperature. That is, too hot and too cold water can induce nystagmus. Can use sterile water, distilled water, or even a tap water. And always warn the patient about vertigo. Before syringing, always ask history of any ear surgery, tympanic membrane perforation. If it is an only hearing ear, do not go for syringing. For syringing, make the patient sit comfortably. Place a towel over the shoulder. Then keep a kidney tray or a bowl below the ear, and gently pull the pinna upward and backward to straighten the ESC. Then introduce the syringe with scalpel or cannula slowly into the ear canal. Direct the tip upward, upward into the canal and slide slowly, introduce it. Then syringe the canal multiple times to remove the entire wax. And then visualize using an otoscope whether it is completely removed. Then dry mop with the cotton swab. If the patient complains of vertigo at any stage during the procedure, abandon the procedure and ask the patient to use ear drops and repeat review after 3 to 4 days. And warn the patient that patient may have a vertigo and give an Stemetil if needed. One of the most common conditions other are foreign bodies in the ear, mainly in casualties, especially in pediatric age group. The removal of foreign body depend upon the nature of the foreign body, location of the foreign body, and cooperative or otherwise patient. If the foreign body is a living insect, first kill the insect with oil, or in OP procedures, OP settings, we can use 2% or 4% lignocane. Then can remove it using forceps, or sometimes if it is large insects like cockroach, you have to remove it under microscope, examination under microscope, and remove it. If it is like an irregular graspable object, paper piece and all, you can use crocodile forceps or Hartmann forceps. And if an organic or vegetable like vegetable seeds and all, do not go for syringing because it may swell up and cause pain. In other one, button batteries, it is always dangerous wherever you put it in the nose, or be it in the nose or in the ear, it can cause leakage, so do not syringe it. If it is a round, hard, smooth, round foreign body like a bead, you can remove using syringing, or you can use a wax hook. And if it is not possible to remove under normally, all these foreign bodies need to be removed under general anesthesia, and especially in children. If the foreign body is located in the lateral canal, it will be easier to remove. And if it is in the medial canal, it will be difficult, and the swelling may be associated with difficult removal, and sometimes may need a post-auricular incision to remove the foreign body. All these foreign bodies can lead to skin lacerations, otitis externa, and if it is in button batteries, facial nerve palsies may be associated, and tympanic membrane perforation and all. If you are attended more than once and more than one type of instrument is used, kindly refer for a ENT specialty, and maybe a patient may require to be removed under, foreign body need to be removed under general anesthesia. And before going, next is the diseases of the tympanic membrane. Most common is acute otitis media, both in pediatric and adult group. Both it is actually viral or bacterial infection of the mucosal lining of the middle ear and mastoid air cell system. The most common route of infection is via the eustachian tube because of the negative pressure in the middle ear. The infection may spread from the spread via the eustachian tube into the middle ear cavity, and negative pressure and infection, and then the organisms may travel from the eustachian tube into the canal and cause infection. Other routes of infection is like hematogenous and through the tympanic membrane perforations or through vents. In patients with chronic adenoiditis, tonsillitis, infections of recurrent pharyngitis, rhinosinusitis, all these cases, the infection can travel from the through the eustachian tube to the middle ear. If the eustachian tube is too patulous or it is a short eustachian tube, then also infection can spread to the middle ear. The risk factors associated with acute otitis media may be genetic or immunofactors, and most importantly, environmental factors like poor socioeconomic class leading to overcrowding, recurrent respiratory infections. All these can predispose to acute otitis media. Daycare exposure, if number of children are more and more children are having acute otitis media or respiratory tract infections, there will be higher risk of acquiring acute otitis media. Use of pacifiers, passive smoke exposures, and also associated with increased incidence of acute otitis media. Syndromes like Down syndrome, craniofacial anomalies also can cause acute otitis media. What will be the clinical features? It is one of the most common cases of severe otalgia, incessant cry in a pediatric casualty, especially in the night. The child will be having a gradually progressive otalgia, a severe pain, especially in the night. Then it may gradually increasing over a period of 2 days. Then it will be after the separation stage, after the release of pus, the pain may be relieved, and there will be ear block and tinnitus. General symptoms like fever, irritability, nocturnal irritation, GI symptoms like abdominal pain and nausea may be present, and the patient may give history of upper respiratory tract infection. On examination, the child will be unwell and irritable child, and the patient will be constantly rubbing the ear. And in children, it will be difficult to visualize the tympanic membrane, and if at all it is visualized, it is more like yellowish pink than red, and we can sometimes, if it is perforated, you can see a blood-stained ear discharge in the external auditory canal. In adult, the tympanic membrane will be, there will be 4 stages, like first stage of tubal occlusion, then stage of pre-separation, separation, and resolution. So initially the tympanic membrane will be retracted, loss of landmarks will be there, then the cartilage, then it will become red indents, card wheel appearance, and there may be perforation in the antero-inferior quadrant and blood-stained ear discharge. The treatment of acute otitis media in adult usually relieved by paracetamol, analgesic and paracetamol like mefenamic acid. And if the pain is not subsiding, then only there is an indication for antibiotic. Other measures like silometazole in decongested nasal drops, oral antihistamines and decongestant can be used. And if there is any discharge, go for oral toilet. In pediatric age group, the antibiotics is antibiotic indications of antibiotic will be if the child is less than 6 months of age, and there is even after 2 days of watchful waiting, the patient is having symptoms, and the patient is initially presenting severe symptoms like vomiting, fever, and irregular course. And if there is any sign of complications, go for an antibiotic. And also in high risk children, and if there is any failure to improve, always change the antibiotic. The drug of choice will be high dose amoxicillin, that is 80 mg per kg per day for 5 days, or amoxiclav can be used. If penicillin is resistant, then allergy can go for erythromycin or clarithromycin or a cefuroxime. And for parenteral route, IM ceftriaxone can also be used. If in spite of all these measures, if the symptoms persist and a child is irritable, then you have to refer the patient to rule out any complications. To prevent further attacks of acute otitis media, the modification of risk factors may help, like changing the daycare, avoiding fast smoking, and if the patient is being bottle fed, ask the mother to keep the baby semi-upright and about the use of pacifiers. Breastfeeding has a protective role, so advice regarding breastfeeding and increase vitamin C intake. Next one is chronic otitis media. Initially, when we studied in undergraduate days, it was like chronic suppurative otitis media, tuberculopanic type of TTD, and acticoandral disease or AAD. Now it is like we have two broad stages like mucosal, chronic otitis media mucosal, and chronic otitis media squamous. It can be active or inactive depending upon the discharge. It is usually a long-standing condition. The clinical features in mucosal type of chronic otitis media will be the patient will be having frank mucopurulent discharge, hard of hearing, and on examination they may be seeing a perforation, anterior, posterior, or total perforation. And for treatment purpose, in the peripheral setup, ask the patient to keep the ear dry, keep a cotton plug while taking bath, and if there is any discharge, can go for a suction clearance and give antibiotic drops like Ciproflox D or Oflox D, like steroid containing ear drops. And if there is pain and inflammation, can go for antibiotics like quinolones or amoxicillin or penicillins. Decongestant cetirizine or CPM can be given. And if the patient is having hard of hearing, recurrent ear discharge, and for army purposes and all, sometimes tympanic membrane perforation need to be sealed. In these conditions, patient may require a surgery. For surgery options, refer patient to an ENT surgeon. The squamous type of chronic otitis media, it's a dangerous type of otitis media. It is unsafe here. The patient may be having scanty, foul smelling, blood-stained ear discharge, and hard of hearing will be more prominent. On examination, the pathognomonic feature will be consteatoma or attic or posterior retraction pockets or perforation. It is associated with more complications. So, if a patient is presenting with any of the symptoms, kindly refer to rule out squamous otitis media. These are basically the common ear conditions, and coming to the common nasal conditions. The pharyngeal of the nose, commonly caused by Staph aureus. It can be due to a trauma from the nose pricking, plucking of nasal vibrissae. It is an extremely painful and tender condition. There may be nasal tip and dorsum will be swollen and red. You can see the pharyngeal in the vestibule or tip of the nose. It can sometimes rupture into the nasal vestibule. For the treatment purpose, apply topical mupirocin and give for any oral antibiotics. If the pus is pointing, IND can be done, but never screws the pharyngeal because it can spread to cavernous sinus and by venous thrombophlebitis. Then is a broader topic like rhinosinusitis. It is an inflammation of the nasal cavity and mucosa of the paranasal sinuses. Latest definition of rhinosinusitis. To diagnose rhinosinusitis, the patient should have at least one primary symptom or plus an additional symptom or two primary symptoms. So what will be the primary symptoms of rhinosinusitis? It is like nasal block, nasal obstruction or congestion, or patient may be having a nasal discharge, anterior nasal discharge or postnasal drip. If both of these symptoms are present, then itself the diagnosis of rhinosinusitis can be made. The additional symptoms like facial pain or tenderness, olfactory dysfunction, and the patient is having hyposmia or anosmia. If any of these additional factors plus one primary symptom is present, a diagnosis of rhinosinusitis may be made. Rhinosinusitis is basically mainly caused by viral etiology, and a lesser number of cases are caused by bacterial rhinosinusitis. For the diagnosis of and for classification purposes, if the duration is like, if mostly by 10 days, if usually the viral cases, it will be resolving. For more than 10 days, and if it is less than 3 months, the acute, it is classified as acute rhinosinusitis. And if the duration of the symptoms is more than 3 months, it is chronic rhinosinusitis. On examination, like endoscopic picture, the patient we may be seeing nasal polyp. There will be mucosal discharge in the middle meatus, and there will be edema or mucosal obstruction in the middle meatus. CT scan may say pediatric. CT scan may show mucosal changes within the osteomeatal complex. In pediatric cases, instead of hypoxia and anosmia, the patient may be presenting with nasal obstruction, nasal discharge, postnasal drip, and cough. That is persistent cough, daytime and nighttime cough. With all these symptoms, always rule out rhinosinusitis. For making a diagnosis of acute bacterial rhinosinusitis, these of these 5, at least 3 should be present. The patient having a colored nasal discharge, severe local pain, the temperature is more than 38 degrees Celsius, raised ESR or CRP, and the patient deteriorates after initial minor phase of illness, that is double sickening, then you have to suspect acute bacterial rhinosinusitis. The treatment of one of the most common cases seen in the OPD patient will be presenting with fever, nasal obstruction, headache. On examination, there will be paranasal sinus tenderness, nasal polyps may be seen, discharge may be seen, and postnasal drip will be history on postnasal drip may be seen. The treatment will be used if it is wait for 2 to 3 days. If the symptoms are persisting and acute bacterial rhinosinusitis is suspected, go for an antibiotic like penicillins, amoxicillin or moxiclav, cephalosporins, microlides like azithromycin or clarithromycin can be given. And to relieve symptoms, can go for intranasal steroid like fluticasone nasal spray or mometasone nasal spray. Saline nasal spray will be helping to relieve the edema, remove the crust, and keep the hydration of the nasal cavity intact. For relieving the pain, analgesics like paracetamol, mefenamic acid can be given. And if any associated allergy is present, you can go for antihistamines. Nasal dosing is also advised. If the patient we treated as presenting with an eyelid swelling, persistent headache, fever, vomiting, visual deterioration, always rule out complication. So refer the patient. Which are the topical intranasal corticosteroids used? Mometasone furoate nasal spray can be used in cases of about 2 years of age. The brand names will be, I just gave the brand names because it will be easier. Momiflo metaspray or mometasone furoate. Fluticasone furoate also can be used about 2 years of age. Furamis can be used. Fluticasone propionate is used above 4 years of age. Flutiflo and Flomist. How to use intranasal sprays correctly? The 3 positions can be used, or the patient can be sitting. And for using the intranasal spray in the right nostril, always use the left hand. And for using the spraying in the right and left nostril, use the left hand. This will prevent inadvertent use spraying in the nasal septal area. Ask the patient to shake the bottle, then ask the patient to look down, keep the nostril, keep the intranasal spray into the nostril, then direct the nostril away from the nasal septum towards the eyelid, then use it 2 times, 2 different directions. Ask the patient to breathe in like smelling of a flower, then wait for 5 to 10 minutes, then change hands and repeat in the other side, and keep the spray closed. Then is chronic rhinosinusitis. Now the chronic rhinosinusitis is classified as with polyposis and without polyposis, and this polyps can be localized or diffused. So there are certain systemic conditions predisposing to chronic rhinosinusitis, or like cystic fibrosis, primary ciliary dyskinesia, sarcoidosis, Wegener's granulomatosis, etc. For that, any patient presenting with symptoms of chronic rhinosinusitis persisting for more than 3 months, and on examination, if you see a polyp, needs a diagnostic nasal endoscopy, so refer to a specialist. For management of chronic rhinosinusitis, intranasal corticosteroid sprays can be used. If the systemic absorption is lower and safer than systemic corticosteroids. Short course of systemic corticosteroids can be given like 14 to 21 days, prednisolone reaching a maximum dose of 30 to 40 mg per day, 30 mg daily. Studies have been done for use of immunomodulatory antibiotics like macrolides and doxycycline, and leukotriene receptor antagonists like montelukast will be beneficial if the patient is having nasal allergy. And for research purpose like omalizumab and mepolizumab can be used, and aspirin desensitization if it is associated with the aspirin and hypersensitivity reaction of Samter's triad. If the patient is having acute exacerbation in chronic rhinosinusitis, antibiotics can be used. Saline irrigation, nasal dousing also has to be continued. These are the complications of rhinosinusitis: orbital, intracranial, bony, and chronic complications like mucocele and pyocele can occur. Other most common presentation is nasal polyp. And now it is regarded as a part of chronic rhinosinusitis with polyposis. It can be localized or diffuse. Like initially in Vingra and all, we have seen like by ethmoidal polypi and androconal polypi. Nasal polyps can be associated with allergy, asthma, then aspirin exacerbated respiratory disease, that is Samter's triad, allergic fungal rhinosinusitis, cystic fibrosis, Young syndrome, Church-Stroke syndrome, etc. Treatment, always go for a diagnostic nasal endoscopy, and if any suspicion is there, always go for a biopsy. For medical treatment of sinonasal polyposis, that topical intranasal steroids can be used, and short course of cortical steroids like prednisolone 0.5 mg per kg each morning for 5 to 10 days, followed by maintenance dose with topical steroid. And surgical treatment may be required if it is diffuse polyposis, functional endoscopic sinus surgery, and polypectomy has to be done. These things has to be taken care. If a patient is having a polyp, it has have a red, fleshy, friable, granular surface, always rule out malignancy. Unilateral polyp, if the patient's age is above 40 years, bloodstained nasal discharge, always rule out malignancy. If simple polyp in child may be a glioma, encephalocele or meningocele, so always aspirate before removal. If it is associated with epistaxis and in orbital symptoms, always refer and go for a higher investigation like CT scan or endoscopy and biopsy. Other one condition, most common condition is in pediatric age group is adenoid enlargement or adenoiditis. Adenoids are actually part of the Walden's ring of lymphoid tissue, and it is mainly located behind the choana or the posterior part of the nasal cavity. The adenoid growth continues rapidly during infancy, and it plateaus between 2 to 14 years of age. Then it rapidly regresses after 15 years of age. So at the peak, the largest peak time will be at 7 years of age. The adenoid size itself is not adenoid size in relation to the choanal orifices more relevant in causing symptoms. The pathological effects of adenoids will be patient will be having recurrent rhinitis associated with rhinosinusitis, recurrent otitis media with effusion because of eustachian tube orifice blockage, recurrent otitis media, and if it is severe, obstructive sleep apnea symptoms will be present. The patient will be presenting with nasal block, nasal discharge because of blocked choana, epistaxis, and voice change, like this nasal tone of voice will be lost. The patient will be having ear block or hearing loss associated with OME, otitis media with effusion, and pain in acute otitis media. The patient will be having an acute adenoid facies, like long elongated facies, upturned upper lip, pinched up nose, and overcrowding of upper teeth, and high arched palate. And because of obstructive sleep apnea, the patient will be having this decreased sleep, so poor academic performance, hyperactivity. This is one condition indication for adenoidectomy. The patient is having severe obstructive sleep apnea syndrome, recurrent otitis media with diffusion, severe uncontrolled acute otitis media, and associated with other conditions, you can go for adenodectomy. But that age group is important. After 15 years of age, the size of the adenoid regresses. The investigation will be nasal endoscopy and X-ray nasopharynx. In the peripheral, we can ask for an X-ray nasopharynx lateral view. In that, there will be an blockage of the nasopharyngeal and oropharyngeal outlet. And patient may presenting with snoring and all. Treatment is now it is like a topical nasal steroids can be tried. If it is not relieved, adenodectomy has to be done. This mild symptoms, we can wait and ask the wait for the regression of tonsil adenoid. Other most common condition is enlarged inferior turbinate, one of the most common causes of referral because of appearance of a polyp. The categories like it can be due to compensatory hypertrophy in case of DNS, and there will be hypertrophy in the opposite side of deviated nasal septum. Sometimes the turbinate may be medially protruding more into the nasal cavity, so it look enlarged turbinate. And if there is hyperplasia of the turbinate head and whole turbinate associated with chronic rhinitis, and in chronic sinusitis due to postnasal discharge, there may be hyperplasia of the turbinate tail. All these will cause congestion of inferior turbinate associated with severe rhinitis. Turbinate may be enlarged, and the turbinates are actually congal bone which is attached over the attached to the lateral wall of the nasal cavity, and will be on palpation. It will be bony hard, and along the floor of the nasal cavity, it is fully visualized. Congestion of the turbinate can occur normally during nasal cycle. To differentiate it between with polyp, we can use a topical decongestant like xylometazoline drop. If it is decongested, usually it indicates turbinate. If it is in chronically congested, in case of chronic rhinosinusitis, it has to be removed if it is causing severe obstruction. The patient usually presents with nasal obstruction, snoring, obstructive sleep apnea, and symptoms of rhinitis or rhinosinusitis. Always take a history of rhinitis medicament. Also, patient will be using over-the-counter nasal drops like xylometazoline or oxymetazoline drops, which may lead to swelling of the inferior turbinate and one of the major causes of inferior turbinate hypertrophy. Sarcoidosis can rarely present as a cause of inferior turbinate hypertrophy. On examination, the anterior head of inferior turbinate will be congested and will be presenting as a red swelling. If it is associated with allergy, severe allergic rhinitis, there will be pale purplish swelling. One of the most common cause of referral in general practices like to confusing and inferior turbinate with the polyp. For examination, I'll use a nasal topical decongestant, and then if it is decongested, it is usually inferior turbinate hypertrophy to differentiate with polyp. And for treat the associated conditions like if it is rhinitis medicamentosa, stop the usage of the drops. Treat the allergic rhinitis, chronic rhinosinusitis, and if it is still persisting and it is causing severe symptoms, we can go for turbinate reduction surgeries or turbinectomy. Next one of the most common nasal ENT emergencies is epistaxis. So it is like a bleeding from the nose. For classification, it is like childhood is less than 16 years of age and adult cases more than 16 years. It can be primary. It is most commonly 70 to 80% of epistaxis is idiopathic, and secondary causes like trauma, surgery, anticoagulant usage can be associated. Depending upon the site, it can be anterior or posterior. Anterior to the pyriform apertures, that is in the anterior part of the nasal septum, vestibule, and mucocutaneous junction, that is just anterior portion, it will be anterior epistaxis, and behind the posterior part of pyriform aperture, it will be posterior. That is majorly inside the nasal cavity. It can be in the lateral wall, septum, or floor of the nasal cavity. And posterior bleeding may require sometimes surgical management or nasal packing. Adult primary epistaxis more commonly seen in winter and autumn seasons, associated with the use of excessive use of aspirin. If the patient is having anticoagulant aspirin usage, always go for a medical consultation before stopping aspirin. In cases of epistaxis, most of the patients we usually see like alcohol patient is under consumed alcohol. In spite of normal platelet count and coagulation profile, there may be prolongation of bleeding time associated with alcohol usage and increased chance of trauma associated with it may cause epistaxis. Hypertension, actually, more patients we see patients with epistaxis will be having a raised BP, but per se there is no causal relationship. And deviated nasal septum and also can be associated with epistaxis, especially super, but no causal relationship has been established. For adult recurrent epistaxis, it is usually minor and self-limiting. In that case, always rule out aspirin use, chronic liver diseases, septal perforation edges, bleeding, and nasal tumors. But in nasal tumors, usually it will be blood stain nasal discharge. For secondary epistaxis, the cause is actually known, like associated with coagulopathy of liver disease, malignancies, leukemia, myelosuppressive conditions, post-surgical cases, warfarin usage, hemorrhagic telangiectasia. And in these cases, surgical management is better than for surgical management. The patient may require anterior nasal packing or posterior nasal packing. And other causes like tumors are usually present with instead of blood frank epistaxis usually present with blood-stained nasal discharge, but cases like juvenile nasal angiofibroma, hemangiopericytoma can present with severe epistaxis. JN is usually seen in adolescent male child. Pediatric epistaxis, usually the site of bleeding is like the Little's area, where is a thistle black plexus, both external and internal carotid artery are supplying, or bleeding may be from the retrocolumnar veins, that is from this area. And the child will be having, on examination, there will be local dryness and crusting in the septal area. And it is proposed that there is a increased chance of colonization by Staph aureus in that area, leading to neovascularization of the septal mucosa. And when the child is using nails inside it, digital trauma can cause bleeding. When the child is presenting like unilateral epistaxis and is associated with a foul smelling nasal discharge, always consider foreign body as the first diagnosis. This picture shows the nasal crusting and neovascularization in the nasal septal area. These are the wide causes of pediatric epistaxis. How to do a complete clinical examination, look for pallor, jaundice, facial puffiness, petechia, purpura, or other bleeding areas, associated trauma, antenatal or postnatal, rule out, and if it is antenasal or postnasal bleeding, bleeding from the ear or bleeding from any other areas, look for vitals, check the vitals, and local examination, whether it is make the patient sit comfortably and assess the site of bleeding. If there is associated crusting, polyps, tumors, foreign body, and complete blood count can be done. Bleeding time, clotting time, PT with INR and APTT has to done to rule out secondary epistaxis. If the bleeding is severe and it is from the posterior part, refer. First, initial step, like reassure the patient, pinch the nose over the soft cartilaginous part of the nose, align nasal for 10 to 15 minutes. That is a Hippocrates procedure. And ask the patient to slit slightly forward and mouth open. That is the Trotter's method. And keep a bowl beneath the mouth to collect the epistaxis. Then apply oxymetazoline nasal drops and pinch the nostrils. And if it is controlled and on examination, if it's If you see nasal crusting and you can apply naproxen or neomycin cream twice daily for 2 weeks. And if the bleeding site is visualized, a single point is seen over the nasal septal area, can use a cauterization with a soft cotton swab, dip it with 75% silver nitrate, hold it for 5 seconds, then apply a topical antiseptic like mupirocin, and then cover it with a soft paraffin to prevent bleeding. And if the BP is high, you can give for an antihypertensive and refer the patient. The common diseases of the ear, throat. Pharyngitis is one of the most common conditions. As Jinesh mentioned, most of the cases now COVID is increasing. One of the major causes of COVID clinical features will be fever, sore throat, and myalgia. If it is generalized infection of the pharynx, it is, and it can be localized like tonsillitis. It can be causes can be infectious or non-infectious. Infectious like bacterial and viral. Non-infectious causes of pharyngitis include dry air, especially using air conditioners, gastroesophageal reflux disease, smoking, postnasal chemical injury, neoplasia, prolonged endotracheal intubation can all lead to pharyngitis. 40 to 60% of cases are viral pharyngitis, and 5 to 30% bacteria is isolated, and 30% no pathogens may be identified. Group A beta hemolytic streptococcus is the most common cause of bacterial pharyngitis. The patient usually present with fever, sore throat, chills, myalgia, headache, abdominal pain, and anorexia. Nowadays we are seeing more number of these type of cases in the OPD, like fever, sore throat, and myalgia, and there may be history of contact, especially in case of COVID. Now, H1N1 cases are also coming. The patient also may present with similar features. It is actually difficult to differentiate between bacterial and viral pharyngitis. If it is associated with specific viral infection, they will be having a characteristic feature. If it is with adenoviral conjunctivitis with pharyngitis may be associated. In infectious mononucleosis or glandular fever, the patient will be having fever, sore throat, and on examination, there will be exudation over the tonsils, extensive vas membranes, and associated with cervical lymph node enlargement. On blood examination, there will be leukocytosis, and atypical lymphocyte count will be more than 10%. Ball Bunnet test will be positive. Herpangina is another condition, Coxsackie A virus or herpes virus. It may be associated with papillovesicular lesions in the skin. One of the other condition which is most commonly seen in nowadays in OPD is the hand-foot-mouth disease. It will be also presenting with sore throat, and there will be vesicles in and around the oral cavity, inside the oral cavity, then vesicles in the hand, knees, under the feet, and on the buttocks. On examination, there will be generalized pharyngitis, red congestion and all. If it is tonsillar enlargement, there will be tonsillar exudates may be present, tender anterior cervical lymph node enlargement, fever, and absence of cough. That is a central scoring system is used. That is, if there is tonsillar exudate, tender anterior cervical lymph node enlargement, and there is a history of fever and absence of cough. It is if more the number of score, that is you will be giving a score of 2 for each, and if more the number of score, it is more favorable for bacterial pharyngitis. There may be associated pharyngeal erythema, enlarged tonsil will be enlarged like follicles may be seen, or the whole tonsil will be enlarged like parenchymal tonsillitis, and membrane may be seen over the tonsil. And sometimes the tonsillar crypts may be filled with necrotic and purulent exudates, and soft palate petechia may be seen. Always look for associated features like already mentioned in viral diseases to make a diagnosis. Most common causes of pharyngitis is viral and usually self-limiting. Ask the patient to go take a proper voice rest, a warm saline gargle. To relieve the pain, you can use NSAIDs or paracetamol. Ibuprofen or paracetamol can be used. And the pain is persisting, like then only go for antibiotics. Streptococcal pharyngitis itself is self-limiting cause of 5 to 7 days, and if the patient is having severe symptoms, odynophagia, difficulty and pain while swallowing, then go for antibiotics. For antibiotic of choice like penicillin B is can be given 500 milligram QID for 10 days. That is a gold standard treatment. Can for plain amoxicillin, amoxiclav, cephalosporin like cephalexin or cephadroxil. Palm saline gargle and use of taking plenty of fluids like proper hydration, avoiding cold foods and all helps in rapid relief of symptoms. In case of penicillin resistance, you can go for erythromycin or clarithromycin. In infectious mononucleosis, that is, patient is having associated lymph node enlargement and we see an atypical lymphocytosis. Please avoid ampicillin or amoxiclav because it can cause a rash. If the patient is saying recurrent pharyngitis or tonsillitis, benzathin, penicillin, cefuroxime or clindamycin are the antibiotics of choice. Tonsillectomy may be done in cases of severe acute tonsillitis, and the criteria for acute tonsillectomy in cases will be the patient is the symptoms are generally due to the symptoms of sore throat is specifically due to acute tonsillitis. It's not generalized cause of pharyngitis associated with it. It is specifically due to tonsillitis, nor are the area of pharynx is involved, and there will be 7 or more episodes of severe episodes of sore throat. That the episodes are debilitating and affect the normal daily functioning. And if such episodes, more than 7 episodes in 1 year, or 5 episodes per year for last 2 years, or 3 episodes per year for last 3 years. All these criteria, if any of this are present, you can go for tonsillectomy. This is sign criteria adopted from Paradise, Italy. The complications of pharyngitis or acute tonsillitis will be peritonsillar abscess, parapharyngeal abscess, retropharyngeal abscess. Non-separative complications include rheumatic fever, post-streptococcal rheumatoid arthritis, post-streptococcal glomerulonephritis, pediatric autoimmune neuropsychiatric disorders associated with streptococcal infection, and scarlet fever. One of the complications of acute tonsillitis or tonsillar separative complications need a special mention, that is a peritonsillar abscess or the QC. It is actually the collection of pus between the fibrous capsule of the tonsil, it is usually at the upper wall, and superior constrictor, between the fibrous capsule of the tonsil and the superior constrictor muscles of the pharynx. It is most commonly seen in 20 to 39 years of age. Male gender is more commonly seen. Smoking, poor dental hygiene, immunodeficiency diseases always predisposed to acute peritonsillar abscess. Acute tonsillitis may not be always associated with all cases of peritonsillar abscess. So hypothesis is that only 68% of cases are QC were associated with previous history of acute tonsillitis. Another one here is a Weber gland block. That is Weber gland, a minor salivary gland, which are located over the supratonsillar fossa. They help to clean the tonsil and the peritonsillar area. If they are blocked due to poor oral hygiene or dental hygiene, they can cause QC. Clinical features will be progressive unilateral sore throat. The patient will be presenting with the unilateral sore throat progressing over a period of 3 to 4 days. There may be pain on patient will be proper.
severe sore throat, severe odynophagia. There will be painful swallowing and switch initially for solid, then progressing to liquids. Patient cannot swallow his own saliva. There may be drowning of saliva. I develop a sudden hoarseness of voice. I don't know why. And there may be difficulty, pain on opening the mouth and rhythmus. Ipsilateral otalgia may be associated. Am I audible now?
Yes, it's audible.
The patient may be having a fever or headache, and on examination, there will be ipsilateral lymph node enlargement. The patient may be having a hot potato voice because of the diffuse enlargement of the peritonsillar abscess, and limited mouth opening is pathognomonic of quinsy. On examination, the tonsil will be medially displaced. There will be hyperemia of the anterior pillar, bulging of the mucosa of the peritonsillar space, and associated ipsilateral jugulodigastric lymph node enlargement. Infectious mononucleosis is actually associated with bilateral quinsy. If the patient is having any of the symptoms, like the patient is having severe sore throat, difficulty in swallowing, pain on swallowing, initially starting with solid, then later progressing to solid, progressing to liquid, even if the patient cannot swallow his own saliva and having difficulty in opening the mouth, kindly refer the patient to rule out quinsy. And classically, we can see there will be a difficulty in opening the mouth, and peritonsillar swelling will be seen. The surgical drainage is the treatment of choice. Needle aspiration can be tried, and in casualty we used to do quinsy forceps like Kundum-Walter forceps, which we used to drain the quinsy. This incision is put over the most pointing part, or the junction at the junction between the upper pole and the most bulging point, perpendicular point. After draining, you have to go for a combined antibiotic with penicillin and metronidazole, and saline gargle and hydrogen peroxide gargles are usually prescribed. And in case of penicillin resistance, you can go for erythromycin or clarithromycin. Single IV dose steroid with dexone can help to reduce the sore throat, pain and trismus, and reduce the stay in hospital. To relieve the pain, you have to go for analgesic like diclofenac or mefenamic acid or brufen. To relieve the fever, can give for paracetamol. If to prevent dehydration, because the patient cannot swallow, ensure adequate hydration with IV fluids. In case of children, abscess tonsillectomy can be performed, like in the presence of quinsy, tonsillectomy is done. That is called abscess tonsillectomy. In adults, if the patient is having recurrent episodes of quinsy, 4 to 6 after the episode of quinsy, can go for tonsillectomy. That is called interval tonsillectomy. So I've skipped some major topics like evaluation of vertigo, evaluation of hard hearing loss, because they are itself they need a special topic presentation, because they need detailed evaluation. And allergic rhinitis also have been skipped because this is a very lengthy topic. Hope everyone is clear about it, and thank you for patient listening. If any questions, kindly ask or put in the chat box. I just once mentioned one more case, like I just kept a slide like diphtheria. In health service, it is one of the major causes of membranous tonsillitis. I kept it as an additional slide because I don't know whether it will be time, so I kept it as an additional slide. So it is like a diphtheria is caused by Corynebacterium diphtheria. It will be having on examination, there will be fibrous gray pseudomembrane, dirty brown looking leather-like looking membrane over the tonsil, and can extend up to the other areas of pharynx and larynx. And when we try to remove it, it can cause bleeding.
and there will be marked cervical lymph node enlargement, and will be having a bull neck appearance. We had many cases of diphtheria in the past years. For past 2 to 3 years, we did no many cases are seen, but 2018 and 17 period, we had cases of diphtheria. It can cause significant airway obstruction, exotoxin production, and which may lead to myocarditis and neuritis. So for diagnosis, you use the throat swab and put it in lawless medium, and we can see a tiny culture appearance in culture. Depending upon the stage of presentation and associated symptoms, antitoxins are given for treatment. Antibiotics like penicillin or erythromycin 400 milligram QID can be given. Always monitor the airway. If there is any severe airway obstruction, intubation or tracheostomy has to be done. And the patient has to be monitored for cardiac and neurological complications up to 3 weeks. And always take a history of vaccination. Always unimmunized child, partially immunized child, usually presents with diphtheria. So history of immunization is very important. And if the patient is after treatment of diphtheria, the patient has to be given 3 doses of TD vaccine, 0, 1, and 6 months interval.
I think we have a question here. Is there any evidence of increased chance of middle ear infection if infants are breastfed in the lying position?
Initially, when we studied in undergraduate days, we studied that there will be increase of chance of entry of milk into the eustachian canal when the patient is being breastfed in the lying position. But latest evidences in latest studies, we don't have any conclusive evidence. But better to pay at least even if the child is being breastfed in a lying position, just elevate the head by using at least our mother's hand. Just elevate the head and give breastfeeding.
And one question is, what is your take on giving Montelukast for a prolonged period, especially in children?
Montelukast, if associated with allergic rhinitis and all, it can be given not for prolonged periods. It can cause mucosal drying and itching and all. So it is not prolonged recommended. Prolongedly use, especially in winter, if the climate is dry and all, you can go for Montelukast. In associated allergic conditions, and Montelukast has a better role, but not for prolonged use.
Any other questions?
Divya, one question. Deviated nasal septum in DNS in kids, what to do? Should we wait up to 18 years?
Deviated nasal septum. Deviated nasal septum is also one of the common conditions in ENT practice. Deviated nasal septum per se does not cause, per se is not an indication for surgery. So the maxillary all the sinuses will develop by about 18 to 20 years of age, up to 18 years of age. So we'll be usually waiting till 70 to 18 years of age. All the paranasal sinuses development will be complete by that age. If the patient is having severe symptoms, then only septal surgery is advised. By about 18 years, if this patient is still having severe persistent headache and other cause, it is a cause of rhinosinusitis and polyps, then can go for surgery like septal mucosal resection or septalplasty. And if there is an external deformity, need for a rhinoplasty.